Hello, Dr. Bogdan. Welcome to the show. Could you just tell us a bit about yourself to our viewers?
Thank you both for having me. My name is Dr. Bogdan, and I'm the clinical lead and national director at the National Academy of Social Prescribing. Thanks for having me.
Well, thank you so much for coming here. Really, it's a privilege to speak to someone like you, especially so high in the hierarchy of social prescribing and so involved into making social prescribing a worldwide thing. So, how would you describe what social prescribing is to someone who has never heard about it before? As you know, many of our viewers trying to raise awareness. How would you describe that?
Absolutely. In simple terms, there's some great research by a professor at UCL called Professor Michael Marmot. And the idea is that our life is influenced by more than just pills, procedures, science, and genes. How we live, how we eat, how we sleep, how much we smoke, how much we drink, all of those things contribute to our health and well-being. And apart from biomedical elements, there's those psychological and social elements that come in. So if a person comes to you, the doctor, and they have an issue which is not biomedical, cannot be fixed by pills or procedures, then in that case, we can introduce something called a social prescribing. Now, social prescribing is a prescription that we can make for someone to access activities and support within the local community. They get connected to someone called a social prescribing link worker, and that individual has a menu of activities. If they like salsa dancing, they send them to salsa dancing. If they like arts and crafts, they get them to do arts and crafts. If maybe they're trying to get rid of some weight, maybe they send them to some healthy eating programs or healthy nutrition programs, and the list goes on. It can be about finances, practicalities, and so on and so forth. But social prescribing in simple terms really focuses on what truly matters to someone as opposed to what's the matter with someone. So we don't just place labels on patients, we move away from the diagnosis and we focus on what is it that they truly need. If they have a headache, why is it that they have a headache? Is it because of a pathological biomedical concept, or is it because they have social or psychological circumstances such as stress, low mood, financial issues that affect their well-being? And in that case, we can access social prescribing.
As a senior figure within social prescribing in the UK, including clinical and global lead within the NASP, how would you describe your role and what does it involve?
It's a very good question. I think it involves a lot of championing and spreading the word. I think there's a lot of physicians out there who perhaps enjoy prescribing pills and doing lots of procedures, but sometimes that's not what people need. And I'm not saying pills are bad, by the way. Pills are very good when necessary and when needed, but there's a point where pills and procedures are not useful. So, for example, in somebody who's lonely or isolated and maybe they lost their wife or they lost their husband, if they live within four walls and they have no relatives and no friends, in that case, a pill will do nothing for their headache. Their low mood will be because they're alone and because they have no friends and no relatives. So I think a lot of championing and convincing of my fellow colleagues and fellow clinicians who need to go beyond pills and procedures and need to realize that our life and our health really starts at home and in the local community. And I think within my role, I of course try to influence policy making as much as possible, champion the subject within the organization, but also within the hospital that I work as part of, and then trying to get other multidisciplinary team members involved. And in my global role, I love flying all over the world and knocking on people's doors and asking if they would like to learn about social prescribing more or less. So I do a lot of presentations at conferences. I speak to lots of politicians, and we've been to 32 countries around the world, and we've supported countries to implement and embed social prescribing because we know it works and we know it makes a difference.
Beautiful. What's one moment or story that made you realize that social prescribing truly works?
I think I have quite a few. But off the top of my head, I will choose one that left a mark on me. There was a patient that I saw in the emergency department not long ago, and she was a teenager of 17 years old. And sadly, she kept on coming to the emergency department 8 times in a row, 8 times over the past 6 weeks. So I saw her on the 8th time in the emergency department. What was fascinating is that I read my colleagues' notes, and they all said that she was a social admission, therefore no medical problems, and that she shouldn't be in the emergency department. And what they did was they sent her back home to her place of residence. And then she kept coming back in, again with chest pain, palpitations, and she said that she feels she's going to have a heart attack. Age 17, from a clinical perspective, that doesn't make any sense. What this person ended up having, I sat down with her and I asked her what really happened. And I took 5 extra minutes of my time as a doctor, which I know are precious, but it was an upfront investment. And I found out from her, she bursted into tears and she said that sadly, she has a newborn baby. Her partner left, and unfortunately now she has to look after her baby. Her family said that they kicked her out of her house, and now she's living on her friends' couches. And so what she's doing now, whenever she thinks about looking after her child and her newborn, she feels like her world was ending and the walls are closing on her. Obviously, if I was in that situation, I'd probably feel the same. So there was nothing pathologically wrong. I did my ECGs, I did my bloods, I did all of the tests. all came back normal. Therefore, we would send her back home and we would say, there's nothing wrong with you. But is there something wrong with her? Yes, of course there is. Her social circumstances, her financial situation, the world that she's living in, she feels the walls of her world closing in on her. Therefore, she feels there's no escape. And she will keep coming back to hospital. So my job as a doctor is to do good. By sending her back home to what made her sick in the first place, I'm shooting myself in the foot and I'm actually doing harm. So in that case, what did I do? I spoke to her and then I said, unfortunately, there's not much I can do because I'm here in the emergency department, but I can refer her to social prescribing. And she started talking to the social prescriber. She found out that there was lots of support she can get, benefits she could apply for, support, financial support. She then ended up getting a job. And then I got a letter 6 months after, and they said that she now has a house, she now has a job, she has someone to look after her newborn, and she's restarted her life all completely from scratch. For me, that really illustrates the power of social prescribing. And a second really quick example of what social prescribing can truly do is an asthmatic child, someone that kept coming back to our emergency department with asthma and shortness of breath. We kept giving them inhalers. They would come back to us in the emergency department. We escalated their drugs to the maximum dose of steroids and of inhalers that we could give them. They ended up in ITU. They would come back again and again. Why? We then sent them to social prescribing. Social prescriber went to their house. They visited the house. Surprise, surprise. They saw mold on the walls, dampness into their house. It was actually the living circumstances that were causing the breathing and their asthma exacerbations. So in that case, you can clearly see how, yes, they had asthma. That was a biomedical construct. That's a scientific issue that it's affecting their body. But at the end of the day, their deeper issue was the way of living and their house and the fact that the family didn't know they can get those repairs, and those triggers that would trigger their asthma, such as mold and dampness, were still there. So I could give them the best drug in the world, but then I would still send them back home to what made them sick in the first place. So social prescribing works at the core of the problem. It works at the heart of the issue. Social prescribing focuses on what matters to the individual, solves that so that the patient doesn't have to keep coming back again and again and again. And with that, it saves us money, it gets people better, and it works for the doctors and the patients alike.
Amazing.
And for our last question for today, what's one thing you wish policymakers knew and better understood about social prescribing?
My top takeaway for policymakers in this sphere is that they need to understand that it works and that the evidence is there, and that since including and embedding social prescribing into the National Healthcare Service in the UK, our unplanned emergency admissions have reduced between 15 to 25%, and our family medicine appointments have decreased by 40%. If I created a drug, a pill, that could decrease admissions by that much, I would have received a Nobel Prize by now. But guess what? Social prescribing is not a pill and it's not as fashionable. And so I think we need to urge policymakers to look at the evidence behind social prescribing, get better evidence if we're not happy with the current evidence, because of course, there's so many confounding factors when we think about what impacts people's lives. Get better evidence, but we can't have better evidence without more research. We can't have more research without more funding. Therefore, we need more funding into the research for social prescribing. And that's what I probably urge policymakers to do. But I would say, all in all, social prescribing is here to stay. We have for far too long provided what we call a sick care model. So we've always been fixing people, yeah, a revolving door. One patient comes in, one patient comes out, yeah, putting plasters, but water keeps falling out through the plaster. So we put another plaster and then we shoot ourselves in the foot again. We pass the patient from one side to the other. We now need to solve the root cause of their problem. And that root cause is solved through elements such as social prescribing.
Absolutely. Thank you for your time today, Dr. Bogdan, and giving us a brief overview into the positives of social prescribing.
Amazing. Arthur, Srihari, and the whole team, thank you very much. You're fantastic students, and I believe social prescribing is in safe hands in the UAE. Thank you.
Thank you so much. Thank you.